Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. This webinar is titled Colon and Rectal Cancer Screening and Prevention. The presenting provider is Trinity Health IHA Medical Group colorectal surgeon Stephen Liu. Dr. Liu sees patients at our practice on the campus of Schoolcraft College in Livonia. Welcome, Dr. Liu.
Hello, thank you. Thanks for having me. Welcome everyone to Wednesday Wellness, and thank you for attending. And I'm grateful for this opportunity to speak on something which I'm very passionate about, and that's the topic of colon rectal cancer and screening and prevention. Um, Before I begin, just some background, general background on what a colorectal surgeon is. We're trained as general surgeons, and then with additional training to specialize in treating diseases of the colon, the rectum, and the anus. And in particular, we offer screening and surgical management for colon and rectal cancer in our practice. A very common question I get asked by my patients who have been diagnosed with colorectal cancer is if they could have been caught, if their disease could have been caught earlier or prevented. And sadly, the answer is yes. And so I'm going to share with you all how to do that today. So first off, basically, what is colorectal cancer? It's the uncontrolled cell growth on the inside lining of the colon and rectum that can invade past the wall and to other parts of the body if left untreated. Most colon cancers start as a polyp, and over time, genetic mutations can develop and then lead to uncontrolled growth and spread, or what we call metastases. Colon polyps themselves are very common. They can be found up to 30 to 40% of routine colonoscopies. They're generally categorized between benign versus precancerous, with benign polyps not being able to become cancer, and then precancerous polyps having the chance to become cancer. As you can see in the picture there, the progression from normal colon to then development of a polyp, then a more advanced polyp, and finally cancer. And this usually takes anywhere from 5 to 20 years on average. So colorectal cancer, once diagnosed, we divide it into 4 stages, with stage 1 and 2 considered earlier stage, where the cancer is still confined to the inside lining of the colon and rectum. Stage 3 is when the cancer starts spreading past the wall and into the surrounding lymph nodes. And then stage 4 is once it starts getting into the bloodstream and spreads to other organs, most commonly for colon rectal cancer, that would be to the liver or the lungs. Colorectal cancer is quite common. It's the 4th most common cancer in the US. Every year, about 150,000 Americans are diagnosed with colorectal cancer, and more than 50,000 people will die from it each year. On average, 1 in 24 people will be diagnosed in their lifetime. The average age of diagnosis is 66, and currently more than 1.5 million uh, colorectal cancer survivors live in the US. So as you saw from the previous statistics, um, it generally affects us as we get older. And so our risk of getting colorectal cancer increases as we age. This is mostly because then you have more time to develop those genetic mutations, the longer you live. There is a slightly higher incidence in men than in women, and certain race and ethnicities, such as Black individuals and Native Americans, are more likely to be diagnosed with colorectal cancer. Any condition that increases kind of exposure to chronic inflammation will also increase your risk. So patients that have a history of inflammatory bowel disease, such as Crohn's disease or ulcerative colitis, a personal or family history of colon rectal cancer or colorectal polyps can increase your risk as well. And more rarely, but some genetic syndromes are associated with higher risk of developing colon cancer at an earlier age. And those would be like familial adenomatous polyposis, or what we call FAP, or hereditary non-polyposis colorectal cancer, also known as Lynch syndrome. Other environmental and lifestyle factors have also been shown to increase the risk for developing colorectal cancer. And generally, this is thought to be exposure to certain carcinogens or chronic microscopic inflammation as a result of these risk factors. And so that would be type 2 diabetes, having a personal history of abdominal or pelvic radiation, um, generally low physical activity, obesity, smoking, heavy alcohol use, a diet that's low in fruits and vegetables or fiber, and then diets that are high in red and processed meat. Colorectal cancer is often presents actually without symptoms, but some of the things to be looking out for would be any unexplained weakness and fatigue, changes to bowel habits such as persistent diarrhea or constipation, or any narrowing or thinning of the stools, any blood in the stools or blood in the toilet, or blood with wiping, anemia, which is low blood levels, sometimes can be the first sign of that you might have colorectal cancer. Um, any unintended weight loss, feeling that bowels don't fully empty, or unrelenting cramping or abdominal pain. Because it can be a silent disease, it's all the more reason that screening is so important. And certainly don't ignore any new signs or symptoms and seek medical attention or speak to your doctor as soon as possible. So there has been significant progress in the fight against colorectal cancer over the past 30 years. Colorectal cancer rates have decreased every year in patients over 55 at about 1 to 2%, and death rates have also dropped every year in patients over 55. Um, Over 90% rate of survival uh, if treated at an earlier stage. So those would be the stages, early stage 1 and 2. However, despite these improvements, 1 in 3 eligible adults are not getting the screening that's recommended. So there's certainly still progress that can be made. What is concerning, more recently, it's been found that colorectal cancer is rising in young adults. Now, 20% of colorectal cancers are being diagnosed in people under 50, whereas 30 years ago, that was only 10%. So it's doubled in that amount of time. It is now the deadliest cancer in men under 50. And if this trend continues in 2030, it's estimated to be the deadliest cancer for both men and women under 50. Although it's not clear why this is happening and is current area of research. There are some plausible causes, including greater exposure to the potential risk factors that I mentioned earlier, such as the Western style diet that's higher in animal fat, red meat, low in fiber, um, increasing rates of obesity, and decreasing physical activity amongst the population. The good news is that colorectal cancer is preventable, and the best way is through screening. As a direct response to the rising rates of colorectal cancer in young adults, the screening recommendation has been lowered to age 45 from 50. And so all average risk individuals is recommended to start at age 45. In this way, we can find precancerous polyps and remove them before they have a chance to become cancer. And we can also find cancer at an earlier stage when treatment is more effective. And It's estimated that with routine screening, 2 out of 3 colon rectal cancer deaths can be avoided. There's many screening options that are available, all of which have been approved. Uh, the best screening is the one that uh, you'll be able to do and adhere to and follow the recommendations. In general, the screening options are divided into direct visualization tests versus stool studies. Amongst the screening test, colonoscopy is considered the gold standard because we're both able to diagnose and treat anything that we find. It's the only test that we're able to do that. Um, with a normal colonoscopy on your first screening, um, you're able to then follow up every 10 years. Similar test, a flexible sigmoidoscopy is also a screening option. In this case, the scope is only passed to the lower part of the colon, and normal test would require a follow-up every 5 years in this situation. More indirect visualizing screening is a CT colonography, also known as a virtual colonoscopy. It still requires a bowel prep. However, there's no sedation to do this, to do a CT scan. It takes about 5 to 10 minutes. Um, because any findings typically still have to be followed up with the colonoscopy, it's not often recommended. More commonly, we now use it to whenever a colonoscopy is unsuccessful for other reasons. With a negative test, the follow-up would be 5 years. Because of because it's used as more as an adjunct to colonoscopy or a backup to colonoscopy, often if something is found, then then it may require potential surgery. Stool-based screenings have certainly become more popular. Cologuard is the most recognizable one. These you can do from home, are non-invasive, uh, and require some form of bowel movement or sample from bowel movement. Cologuard specifically looks at microscopic stool DNA, as well as microscopic blood in the stools. And in this case, you have to submit an entire bowel movement for the test to be effective. Um, and it has to be repeated every 3 years. The fecal immunochemical test, as well as the fecal occult blood test, both have to be repeated every year for negative tests. And these, you don't have to submit an entire bowel movement, just a sample. Um, I should note the fecal occult blood test, that specifically needs a sample from 3 separate bowel movements. And any one of these tests, if they become positive, need to be followed up with a colonoscopy. So everything that was recommended previously, those apply to average risk individuals. And so if you're considered to have to be in a higher risk or have one of these higher risk features, you have to follow a different set of guidelines. And so specifically for patients that have a family history of colorectal cancer or advanced polyps, it would be recommended to start screening at age 40 or 10 years younger than the earliest family member that's diagnosed. So for example, if your father was diagnosed with colon cancer in his 40s, then you would have to start screening at 30. And then a normal follow-up interval would be every 5 years rather than every 10 years. Patients with inflammatory bowel disease, again, such as Crohn's disease or ulcerative colitis, they're recommended to start screening 8 years after their initial diagnosis, because that's about the time it takes to have enough inflammation to increase their risk of developing colorectal cancer above the average risk individual. And that should be repeated every 1 to 2 years. For patients with Lynch syndrome, they should start at age 20 to 25 and repeat it every 1 to 2 years. And then patients with FAP start even earlier at age 10 to 12 and repeated yearly. So because colonoscopy is our gold standard screening recommended test, I'm going to spend some time to uh, describe what getting a colonoscopy is like. This test can be done in an outpatient surgical setting or outpatient hospital setting. You don't have to stay in the hospital overnight. You do have to set up someone to drive you because most patients are sedated during the procedure. And the most dreaded part of the colonoscopy is doing the bowel prep. And so there's not a number of different bowel prep options that are available. The one that we use, the two that we use most commonly in our practice would be the Suprep, which requires a prescription. And here you drink 2 bottles of bowel prep, total of 32 ounces of fluid, followed by additional 64 ounces of water. Um, the other bowel prep that's available is just over the counter, and that's a combination of Dulcolax and Miralax, both laxatives. And this would require a total of 64 ounces of fluid as well. Usually drank the night before, and then so it's split into 2 parts. First half is drank the night before, and the other is usually drank the morning of your procedure. It's really important to stay on clear liquids the day before your procedure as well. And I want to emphasize that if you only drank the bowel prep and drank nothing else, you would come in very dehydrated, and that's the last thing we want when you come in for the procedure. So it's important to drink additional fluids on top of the bowel prep. Want to help you be successful in completing your colonoscopy, because the last thing uh, we would want is to not be able to get a good look and have to repeat the exam again. One way to increase your chance of success is avoiding high fiber diet, such as raw fruits and vegetables, specifically seeds, nuts, corn, popcorn that can linger in your colon around 3 to 5 days before your colonoscopy. And above all, following prep instructions very closely. So during the day of the colonoscopy, you'll get an IV. Most likely you'll get medicine to make you relaxed and sleepy. This is probably what most patients look forward to. A lot of people say it's the best nap they've ever had, and I guess it's somewhat of a consolation for uh, having gone through the misery of the bowel prep and not getting much rest the night before. You're monitored very closely by the anesthesia team during the procedure. Generally takes about 20 to 30 minutes, depending on what we find and any maneuvers or polyps that we have to remove. And you might feel some pressure during the exam, and there might be cramping afterwards, but most patients don't feel or remember anything. After the procedure, you wake up in recovery area. Um, Generally, your provider will come and speak with you, let you know what they found, what the recommendations are. Um, you'll be given a copy of your report, which is shown in the picture there. You'll be able to return to a regular diet fairly quickly. I generally recommend just kind of eating lighter because you may still have some gas and discomfort kind of throughout the day. And most patients are able to return to work the next day. If there was anything removed or biopsied during the colonoscopy, the pathology results typically take anywhere from 3 to 5 days to get back. So the colonoscopy is a very safe procedure overall. Risks and complications are rare but possible. Those would include bleeding and perforation. Again, very, very low risk of that. Possible risk of infection and anesthesia, complications from anesthesia. Many patients wonder if their colonoscopy is covered by their insurance. Um, Because of the Affordable Care Act, it requires both private insurers and Medicare to cover all colorectal cancer screening tests that are recommended by the governing body, um, which is called the United States Preventative Service Task Force. And those would include all of the recommended screening tests that I mentioned earlier. Um, there's some coverage for diagnostic colonoscopy, but that's when it starts depending on specific types of insurance. Um, One thing that generally is covered is if you choose to have a stool-based test, such as Cologuard, and that comes back positive, then generally the follow-up colonoscopy would be covered as well. Of course, um, as mentioned at the beginning, if there's any questions and you aren't sure, always check with your insurer. So aside from screening as the best way to prevent colon cancer, there are other ways to decrease your lifetime risk. It's primarily by focusing on making changes to the environmental lifestyle factors, or essentially doing the opposite of what would increase risk. Uh, so those would be things like increasing physical activity, something as simple as going on a brisk walk for 20 to 30 minutes a day, keeping a healthy weight generally. That's defined as a BMI less than 25. Um, Eating a diet low in animal fats and higher in fruits and vegetables and whole grains. Limiting red and processed meat intake to about less than 2 servings a week. Limiting or avoiding alcohol consumption. So that would be less than 2 servings of alcohol for men and less than 1 serving of alcohol for women, and avoiding tobacco. And there is, for medical help and management for this, and there's an area of medicine called lifestyle medicine. You certainly talk to your doctor about a referral to that in order to be able to uh, work on all of these and increase your overall health. So although most colon cancers are random or sporadic, um, up to 20 to 30% of colon rectal cancers are associated with family history or felt to be inherited, and 5 to 10% of patients um, that have been diagnosed with colorectal cancer actually have an identifiable genetic mutation. And so genetic testing can certainly change screening recommendations for these patients and inform their family members. Patients that would qualify would include anyone that has a strong family history of colon and rectal cancer, specifically immediate family members diagnosed with colon rectal cancer before the age of 60, or having multiple family members in multiple generations. Anyone that's diagnosed with colorectal cancer before the age of 50, and if you had more than 10 colon polyps removed, then it would be recommended that you have a referral to speak with a genetic counselor and to discuss if genetic testing is right for you. Genetic testing itself is as simple as a blood draw. And that although the primary focus of my presentation is screening and prevention, as a surgeon, I have to speak briefly about the treatment of colorectal cancer, since that's largely what I do. Um, the main takeaway is, and what I tell all my patients is that in general, we consider colorectal cancer to be treatable. And it takes a whole team to come up with the best plan for our patients. From the surgery side, we want to do procedures in a minimally invasive fashion with small incisions. And often is the case we're using the robot or the Da Vinci system. The benefits of this are less pain, faster recovery, shorter hospital stay, and even less future complications. And chemotherapy is another mainstay of colorectal cancer treatment, as well as immunotherapy. This is uh, administered and recommended by the medical oncologists. There's systemic treatment, which is generally through an IV, or there are oral versions of that, or targeted therapies for specific mutations that can be identified. And then radiation is administered, managed by our radiation oncologists. And this was mostly for rectal cancer and targeted at the pelvis. And so when seen, depending on stage, you may get a combination of any one of these three options. And we always meet together and to be able to come up with the best recommended treatment and really tailor it to each individual patient. So you should never feel like you have to face um, either screening, prevention, or diagnosis of colorectal cancer alone. There's many resources and organizations that are available. There's professional societies such as the American Society of Colorectal Surgeons, the American Gastroenterological Association. There's more grassroots support groups such as the Colorectal Cancer Alliance and Fight for Colorectal Cancer, or nonprofits like the American Cancer Society. And then there's government supported organizations and large consensus group such as the National Comprehensive Cancer Network, which provides guidelines for um, best practice guidelines for all cancer types. So if you take nothing else away from this talk, um, I, I want you to at least know that colonoscopy is the gold standard for screening methods. Colorectal cancer can be prevented, and prevention saves lives. And screening for colorectal cancer is now recommended starting at 45 for all average risk adults, due to specifically the rising cases in younger adults. So with that, thank you all for your attention, and I'm happy to answer any questions.
Awesome. Thank you, Dr. Liu. So we do have a couple questions in there already. If you have a question you'd like to ask, you can put it into the Q&A feature, which is at the bottom of your Zoom screen. You can submit your question anonymously. Just please select that option before submitting. All right, so I will start with the couple that we have in there. So how soon after chemo treatment would you recommend a follow-up colonoscopy?
Yeah, so without knowing kind of more of the specifics, the in general, follow-up colonoscopy after a diagnosis of colon rectal cancer is recommended 1 year after your diagnosis or surgery. If you ended up having chemotherapy first, um, like some might for rectal cancer, um, then the follow-up would be at kind of restaging intervals or when you've completed. In general, afterwards, we would want to wait about 4 to 6 weeks after completing a chemo cycle to be able to do a colonoscopy. And then the continued follow-up after that initial year would then be 3 years and then 5 years, as long as the repeat colonoscopies are normal.
And is that for all ages, or does that time get shorter as you get a little bit older? So for everyone.
That would be for all ages.
Okay,
Yeah,
so you can expect that you wouldn't necessarily have to have one every single year if your results are looking good.
correct.
Okay, that's great. Okay. Is someone who has celiac disease at a higher risk for colon cancer, especially if they have a history of severe constipation?
So celiac disease itself has not been identified as like a specific cause or higher risk for colon cancer, um, nor is constipation a risk factor necessarily. It's really more those conditions that we've seen that increase chronic inflammation, or are more aggressive, such as the inflammatory bowel diseases.
Okay. And can you tell us, sorry, one second, I was just lost the question I was reading. So, understanding the colonoscopy is the number one gold standard to screen. What is the second best that doesn't require sedation?
Yeah, so again, the best screening is the one that you will do, because any screening is better than no screening, and so all of those are any any of the other options are essentially second best as long as you're able to continue to adhere to that. I think often many patients choose to do the Cologuard because that gets delivered to your home and it has a little bit longer interval of 3 years rather than some of the other stool-based ones that have to be done every single year. And so you really don't get the benefit of it if you're skipping any of those tests on any given year.
Do you have to start? So, if you turn 45, do you have to start with a colonoscopy before you can go into any of the other types of tests, or is it sort of up to you?
Yeah, it's up to the patient. All of the tests that we talked about today, the stool-based test, the colonoscopy, flexible sigmoidoscopy, even the CT colonography, virtual colonoscopy, those are all recommended as initial screening tests.
Okay. And can you have a colonoscopy without sedation?
Um, it it can be done. Patients do it. It's very select few do it because sedation is so safe these days. And however, I would not recommend it because there is a higher chance that we're not able to complete the colonoscopy due to discomfort or pain that might be felt during the procedure.
Okay. And so there are several patients on here who are asking. So this particular one says she's 78 and in great health, had several colonoscopies, and has not had any nothing cancerous show up. So last year the surgeon told her that she doesn't have to have another one because of her age. Can you explain why that is?
Yeah. Um, so when we would recommend to stop colonoscopies um, is on average 75. But then between 75 to 85 is more on a case by case or individual basis, depending on your previous risks or previous health history or previous polyps that have been found. And so, and then also based on kind of your general health. And the reason we stop is because because colon cancer takes anywhere from 5 to 10 years to develop, at some point we're not getting any more benefit by doing the screening. And so, however, uh, in patients that that are living to 95 to 100, we are diagnosing colon cancer in those patients, which could have potentially been prevented if they had been continued with screening or with colonoscopies from 75 to 85. So in general, it's in once you're in that age group, it's a case by case basis.
Okay. Um, and it looks like someone had surgery for stage 1 colon cancer and developed a neurological disease since her surgery. Is that something that can happen from surgery?
Yeah, I'm sorry to hear that. Um, I, with not without again knowing more details and or knowing what kind of neurological disease, I wouldn't be able to speak too much about the cause of that. Um,
Okay. But that's something, if you do find yourself in that same position where you have colon cancer, that's something that you'll discuss with your surgeon, any kind of side effects or risks that come along with that surgery.
Right. The only, yes, absolutely. We would go over all the risks and the potential benefits, kind of the known risks, or the more common risks that can happen. Just as a general statement, um, in don't expect neurological diseases,
It's more
to
of
to
a
occur after surgery. Yeah.
okay. Okay. Um, this person had a bowel resection 12 years ago. Are there any risks of doing a colonoscopy?
Uh, So generally not, as long as there's no changes in bowel habits um or symptoms that would be concerning for like blockage or any symptoms. If it's just that they had a surgery in the past, then it's perfectly safe to do a colonoscopy.
Okay. Again, something to like it sounds like a case by case talk with your surgeon. Okay. I've never heard of this, Dr. Liu. In my last colonoscopy, the doctor noted tortuous colon and had to press on certain areas to advance the scope. Other than eating more fiber, is there a way to overcome this? I've never heard of that condition.
Yeah, so everyone is everyone's anatomy and physiology, there's always some variation within normal. It's the colon, although in the pictures looks nice and straight, it's actually everyone's is kind of loopy inside their belly. You got to fit on average 5 to 6 feet of colon inside your abdomen. And so there's lots of twists and turns. And so a term that we use is that it's tortuous when we're doing a scope and running into more twists and turns. And so to help advance the scope, then we have to apply pressure on the belly, counter pressure on the belly in order to get the procedure done. Um, it's more something that you are born with, having a tortuous colon, not necessarily related to your diet or lifestyle.
And is it something that that will cause issues in your life? I'm guessing this person didn't know that they had one until their colonoscopy. It probably wasn't causing too many problems.
Right. Generally, again, it's something that's described when we do the colonoscopies, and it's not necessarily associated with the symptoms of having like a bowel movement or being constipated.
Okay. There's some questions about diet. So, can you talk a little bit more about why red meat is not recommended or why it kind of has some risks with it? And if you're someone
Yeah.
who has gastrointestinal issues, do you actually recommend eating meat versus vegetables or fruit?
Yeah. So, um, so that data comes from, I mean, these are all large population studies that show association between diet and colon cancer, colon rectal cancer. And so that's where that recommendation comes from. And it it's been shown that diets that are higher um, in like the highest quartile um, of eating red and processed and smoked meats, it's felt that they have higher levels of like nitrites, and that has been demonstrated then in like animal studies uh, and in the lab to be carcinogenic. And so that's where that recommendation comes from. In terms of adhering to either keto or carnivore diet, um, generally would not recommend that, largely because um, it's been shown over and over that high diets high in fiber, specifically from a wide variety of fruits and vegetables, are the best for gut health and gut motility, and actually the most natural way to get probiotics.
Okay, and I know a lot of people say that vegetables or fruit are kind of hard on your stomach, let's say. Is that a matter of just getting used to it? Like if you're someone who doesn't eat a whole lot of vegetables and you start, it's probably going to take some time, I'd imagine, to get used to having that shift in your diet.
Yeah, so part of why it's good for our gut is because a lot of that gets broken down by the good bacteria that's in our colon, and that produces gas. And so a lot of the discomfort is coming from the gas that's produced. And certainly, like you mentioned, when you suddenly switch the diet, it can take a while for your body to adjust to that. I always tell my patients to stick with it. You can always try to ramp up more slowly rather than making drastic changes. And the general goal is to get 20 anywhere from 25 to 35 grams of fiber a day, and can take up to a month for your body to get used to increasing amounts of fiber.
Okay, so
So slow and steady.
yeah, if you are feeling some discomfort, that doesn't necessarily mean you can't, have more plants in your diet. It's just a matter of getting used to it.
Right.
Okay. Um, so after surgery and chemo, are there suggestions for prevention of reoccurrence? I know we talked a lot about lifestyle medicine. Is there anything specifically that can be done?
And so all the things that we talked about for decreasing risk would still apply for decreasing recurrence as well. Um, And in a similar way, that screening is our best prevention. Adhering to what we call like surveillance recommendations is the best way to um, detect recurrence earliest when we can still treat it. And so, as a general note, um, up to 90% of recurrences happen within the first 2 to 3 years after your colon cancer is treated. And so it's in that period that it's important to stay up to have close follow-up with your providers, and have the routine imaging and repeat colonoscopies.
Okay. We have someone talking about feeling bloated when they consume gluten. And then they talk about some polyps outside of the anus, which I didn't realize you could get them outside of the colon. Is that possible?
Um, so that first part was that a
So if you're
question about
feeling,
gluten or
yeah,
just
it looks kind of like a statement, but you could, I guess, kind of, if you're feeling bloated after a specific type of food, so in this case, gluten.
right? So there's certainly there's food allergies, then there's food sensitivities, and then there's actual um, like pathologies to where you'd be diagnosed with something like celiac disease. And so it's kind of a spectrum. And so certainly if you notice a specific food that is irritating to you, I mean, the easiest would be to avoid it. But if it's new and it's concerning, then I would certainly talk to your doctor about that to get that worked up more. Um, and then in terms of having polyps. Uh, so generally polyps, there's of a specific type of tissue that's uh, only lines like gland forming um, organs. And so specifically the colon polyps are found only, those specific types of polyps are only found in the colon and the rectum. Anything that would maybe have like a polyp type appearance on the anus, then we would be concerned about some other pathology.
Okay. And can you talk about some good sources of fiber? So people are asking about beans and also nuts.
Yeah, absolutely. So all of those are great. They're so it's really the best is to get varied sources of fiber. Something we like to say and tell our patients is to eat the rainbow. And so that it's a and those colors are an indication of all the different nutrients that you can be getting um, from different types of vegetables. But certainly nuts, seeds, um, beans, and then uh, all the different various fruits and vegetables.
Okay. Can you talk a little bit about what the term leaky gut means?
So it's kind of leaky gut is um, not really a like a medical diagnosis. It's kind of more like a general term, um, and uh, can mean more in terms of like symptoms that one experiences. And so usually it's applied to symptoms of like having more loose stools or diarrhea as a result of increased like secretion of fluid into the GI tract.
Okay. I'm just looking here for any questions I missed. Um, okay, how about so IBS? Does IBS cause concern for colon cancer? And it looks like not fully emptying the stomach. So IBS, constipation, not fully emptying the stomach are these specific concerns. Do they need to do a screening earlier than the typical 45? Oh, I think, did you get muted, Dr. Lou? I can't hear you. Is it just me? Nope, can't hear you. I don't know why. I think we still can't hear you.
How about now?
Yeah, there we go.
Okay. Um, yeah, so the so short answer is irritable bowel syndrome. It's a different diagnosis than inflammatory bowel disease. Um, Irritable bowel syndrome does not carry an increased risk for developing colon cancer. However, it is a diagnosis that can be worked up with a colonoscopy. And so it would be a different reason for getting a colonoscopy. So screening specifically is for patients that have no symptoms. and we were just recommending at a certain age that everyone should start screening in order to be able to catch polyps, find polyps, or catch early cancers. And however, if you have any changes, symptoms, either constipation or diarrhea or any other GI or bowel symptoms, then certainly part of that workup and talking to your doctor may include a colonoscopy.
Okay. And following radiation for prostate cancer, do you need to be screened for colon cancer more often?
So that depends on the type of radiation that was received for the prostate cancer. In general, so if it's more, if it, and that would also depend on kind of at what point when you got that radiation. If it's any kind of radiation that was more whole body, like in the targeted whole area of your body, like the abdomen or the pelvis, then yes, we would recommend starting earlier at age 40 or 45. Um, but if it's so often, so there's kind of much more localized radiation as well offered for the prostate, or even radiation beads. And in that case, we don't recommend. There's no different recommendation for those patients.
Okay. All right, I think we got to all of the questions. So, we thank you so much for joining us this evening, for those of you who are still on with us, and for submitting questions. Thank you, Dr. Liu, for taking the time during Colorectal Cancer Awareness Month to speak about it and help us understand how we can best prevent cancer. So Dr. Liu again works out of Livonia, correct?
Yep.
Yep. And we actually have practices scattered throughout Southeast Michigan. So if Livonia is not close to you or convenient for you, then we can certainly help you find something a little bit more convenient.